Somewhere between 60 and 80% of adults over 60 wake up at least once per night to urinate. Most of them have been told, in one way or another, that the bladder is to blame. The prostate, the pelvic floor, the simple arithmetic of an aging body that holds less and signals sooner. They've adjusted their evenings around it, reduced their fluids, scheduled their last bathroom visit with increasing precision, and accepted, gradually and without much protest, that this is simply what the body does now. The bladder, it turns out, is rarely the problem. What the research shows, published, peer-reviewed, and sitting largely unread outside of specialist circles, is that in the majority of nocturia cases in older adults, the bladder is functioning correctly. It fills because the body is sending it more fluid than it should be receiving during sleep, generated by systems that most patients never connect to a 2 a.m. bathroom trip. The cardiovascular system redistributing fluid from the legs, a hormone whose nighttime surge has quietly flattened with age, an airway collapsing during sleep and triggering a chain reaction that ends in the kidneys producing urine they were never supposed to produce. Blood sugar elevations that have been running undetected for years, a medication taken at the wrong time of day. The bladder is the last stop. Everything upstream has been ignored. The cost of that misdirection is not limited to disrupted sleep. It extends to falls, to accelerating cognitive decline, to cardiovascular consequences that show up in mortality statistics. And it accumulates, quietly and compoundingly, across every night that the real source of the problem goes unaddressed. What causes the body to overproduce urine during sleep? And why does the standard diagnosis almost always miss it? What does the heart have to do with a 2 a.m. bathroom trip? And why does lying down change everything? Which hormone is supposed to be protecting your sleep every night? And what happens when it stops? Why does the way you breathe while unconscious determine how much urine your kidneys produce? And what is the one timing adjustment, not a new drug, not a procedure, that has resolved years of nocturia for some patients within days of being made? Every one of those questions has a specific answer, and by the time this video is done, you will understand what your body has been trying to tell you every night, in the only language available to it. There's a word most people have never heard that explains why millions of Americans over 50 are waking up at night to urinate, and why most of them have been looking for the answer in exactly the wrong place. The word is nocturnal polyuria. It means the body is producing a disproportionate share of its daily urine during nighttime hours, more than a third of the total daily output occurring precisely when the body is supposed to be resting, recovering, and leaving the bladder alone. And according to research compiled across multiple population studies referenced by the International Continence Society, it accounts for the majority of nocturia cases in older adults. Not a subset, the majority. That single finding changes everything about how this conversation should be framed. Nocturia itself, the clinical term for waking one or more times per night specifically to urinate, where sleep precedes and follows each void, affects somewhere between 60 and 80% of adults over the age of 60, based on data referenced in ICS guidelines. A number that large doesn't describe a rare condition. It describes something so common that it has been absorbed into the background of aging, treated as unremarkable, and largely left unexamined by the people experiencing it, and, too often, by the clinicians they mention it to. It has become one of those symptoms that gets a nod and a note and very little else. What makes that normalization so consequential is what sits underneath the symptom, because nocturia is not a condition that originates in the bladder in most cases. It is a condition that arrives at the bladder after being generated somewhere else entirely. The bladder fills. The bladder signals. The person wakes. But the reason the bladder is filling at 2 in the morning, at a rate it has no business filling during sleep, is almost never a story about the bladder itself. It is a story about the heart, or the kidneys, or the airway, or the endocrine system, or the medication taken at 7 that morning. The bladder is the last stop on a route that began somewhere upstream. in a system that most people, and many clinicians working under time pressure, never think to examine in this context. Understanding why requires a brief detour into what the body is supposed to be doing at night and how elegantly that system is designed when it works correctly. In a healthy adult, urine production follows a clear circadian pattern. High during waking hours, significantly reduced during sleep. The kidneys, responding to hormonal signals that rise as the body prepares for sleep, shift into a conservation mode, producing smaller volumes of more concentrated urine, reducing the load sent to the bladder, and allowing uninterrupted sleep for 6, 7, 8 hours. This is not passive. It is an active, hormonally coordinated process that the body executes every night when the relevant systems are functioning as they should. When that process breaks down, when the circadian regulation of urine production loses precision, when the hormonal signals weaken, when the systems that should be quieting down at night are instead responding to cardiovascular pressure or obstructed breathing or elevated blood sugar. The result is a bladder that fills on a daytime schedule during nighttime hours. The person wakes not because something is wrong with their bladder, but because something is wrong with the system that was supposed to be protecting their sleep. And that system, it turns out, has several points of failure that are remarkably common in adults over 50, and remarkably treatable once they're correctly identified. The most common point of failure is also the most misunderstood, and it begins not with any organ directly involved in urine production, but with a diagnostic habit that has been sending patients in the wrong direction for decades. Consider what happens in a typical clinical encounter when a patient over 50 mentions waking up at night to urinate. The physician listens, makes a note, and the conversation moves, almost automatically, toward the most anatomically obvious destination. In men, it goes to the prostate. In women, it goes to the pelvic floor or bladder capacity. In both, it often ends with a recommendation to reduce fluid intake after dinner, perhaps a referral to urology, perhaps a prescription for an overactive bladder medication that works, when it works at all, by reducing the bladder's sensitivity to the signal that it's full. The appointment moves on. The underlying question, why is the body producing this much urine at night in the first place, never gets asked. This is not a story about bad medicine. It is a story about pattern recognition operating at the limits of its usefulness. The urological pathway is not wrong for every patient. Benign prostatic hyperplasia, the gradual enlargement of the prostate gland that affects the majority of men by their 60s, does reduce urinary flow, contributes to incomplete bladder emptying, and increases voiding frequency, including at night. Overactive bladder, characterized by involuntary contractions of the detrusor muscle, is a real condition with real prevalence in older adults of both sexes. And it does produce urgency and nocturia as primary symptoms. These diagnoses are legitimate. Their treatments have evidence behind them. For a genuine subset of patients, the urological path leads to real improvement. But a genuine subset is not the majority. And the majority, when researchers examine the actual cause distribution carefully, have nocturnal polyuria, excess urine production at night, as the primary driver of their waking. Their bladder is not overactive. It is not failing to hold. It is doing precisely what a healthy bladder does when presented with more fluid than it can comfortably contain during the hours it was designed to rest. The problem is upstream. The bladder is simply the messenger, and decades of clinical habit have been treating the messenger while the message goes unread. There is a particular kind of frustration that accumulates around this misdirection, and it deserves to be named directly. People describe it with remarkable consistency. They follow every instruction carefully. No fluids after 7, double voiding before bed, the medication their urologist prescribed taken exactly as directed. And still, at 1:30 in the morning, they're awake. Still at 3. The conclusion they eventually reach is that nothing works, that this is simply how aging feels, that the body they live in has become unreliable in this particular way, and there is nothing meaningful to be done about it. That conclusion is understandable. It is also, for a large proportion of these people, incorrect. What it actually reflects is not the limits of treatment, but the limits of the diagnosis they received. A treatment aimed at the wrong mechanism will not work, not because the body is beyond help, but because the intervention and the problem are simply not connected. Bladder training does not address cardiovascular fluid redistribution. Anticholinergic medication does not correct a hormonal deficit in ADH production. Alpha blockers prescribed for prostatic enlargement do not open an obstructed airway or normalize nocturnal blood sugar. The treatments are real. The mismatch is the problem. Reframing this begins with a single question that almost never gets asked in the standard clinical encounter, and that, once asked, opens a diagnostic pathway that leads somewhere entirely different. Not, how do we make the bladder hold more? But, why is the body sending this much fluid to the bladder during the hours when it should be sending almost none? The answer to that question does not live in urology. It lives in the systems that govern fluid balance, hormonal regulation, cardiovascular function, and respiratory mechanics during sleep. And the first of those systems, the one whose connection to a 2 a.m. bathroom trip is perhaps the least intuitive and the most clinically significant, is the heart. Picture the body at 6 in the evening. A man in his early 60s has been on his feet most of the day. Some errands, a walk, a few hours at a desk. His ankles are slightly puffy. His shoes feel a little tighter than they did this morning. He notices it, attributes it to the heat or to standing too long, and doesn't think much more about it. He has dinner, watches some television, takes his blood pressure medication, and goes to bed around 10. By 1:30 in the morning, he is awake and walking to the bathroom. By 3:45, he is awake again. He has been managing this for 2 years. His urologist says his prostate is mildly enlarged. He is doing everything he was told to do. What nobody has explained to him is what happened to the fluid in his ankles. When the body is upright during the day, gravity pulls fluid into the lower extremities. In people with even mildly compromised venous return, which becomes increasingly common with age and is accelerated by conditions like hypertension, heart failure, and the use of certain medications, that fluid doesn't stay efficiently in circulation. It seeps into the interstitial tissue of the legs, the ankles, the feet, accumulating across the hours of the day in a reservoir that can amount to a liter or more by evening. It sits there, relatively inert, held in place by gravity and the limits of venous pressure, until the person lies down. Horizontal, the body loses the gravitational gradient that was keeping that fluid pooled in the legs. It begins to redistribute, slowly, steadily, back into the circulatory system. Blood volume returning to the heart increases. The heart, responding to that increased preload, pumps with greater output. The kidneys, sensing elevated perfusion pressure and increased circulating volume, do what kidneys are designed to do under those conditions. They filter more aggressively and produce more urine. The bladder fills. The person wakes. And the fluid that spent the afternoon quietly sitting in his ankles has now completed its journey through the cardiovascular system and arrived, as urine, in a bladder that has no interest in waiting until morning. The American Heart Association has documented nocturia as a meaningful early marker of cardiovascular dysfunction, not a peripheral symptom, but a signal that appears, in some patients, before more recognizable signs like exertional dyspnea or visible edema become prominent enough to generate concern. Research published in the Journal of the American Heart Association has shown that in patients with mild to moderate heart failure, nocturia is among the most consistent and earliest complaints, correlating with the degree of fluid retention and the efficiency of nocturnal fluid redistribution. The heart is communicating through the bladder, and the message is being filed under urology. Hypertension adds a distinct but related layer. Poorly controlled blood pressure, affecting nearly half of American adults over 60 according to CDC data, disrupts the normal nocturnal dip in arterial pressure that a healthy cardiovascular system produces during sleep. That dip is not incidental. It is part of the body's nighttime recovery architecture, and its absence, a pattern clinicians call non-dipping, sustains elevated pressure on the renal vasculature throughout the night. Kidneys operating under that sustained pressure produce more urine than they should during sleep, independent of any fluid redistribution from the legs. The two mechanisms can operate simultaneously, compounding each other in the same patient on the same night, while the clinical record continues to list the chief complaint as bladder frequency. There is a practical implication here that is specific enough to be worth stating precisely. Research has shown that shifting antihypertensive medication from morning to evening dosing improves nocturnal blood pressure control in certain patients. And in those patients, nocturnal urine production decreases measurably. The drug is the same. The dose is the same. The therapeutic goal is the same. What changes is the timing, and the timing turns out to matter enormously for a body whose cardiovascular system is doing its most problematic work between midnight and 4 in the morning. That kind of precision, matching the intervention to the mechanism and the mechanism to the time of day when it is actually occurring, is exactly what gets lost when the conversation never moves past the bladder. And the cardiovascular system is only the beginning, because there is a hormone the body produces specifically to protect sleep from exactly this kind of disruption. And in adults over 50, that hormone is quietly losing its grip. The body, it turns out, has a system designed specifically to solve the problem just described. The overnight fluid shift, the kidneys responding to pressure and volume, the bladder filling during hours it was never meant to fill. It is elegant, precise, and largely invisible until it stops working well, which, for a significant proportion of adults over 50, is exactly what happens. The system depends on a hormone called antidiuretic hormone, ADH, sometimes referred to as vasopressin. Its name describes its function with unusual clarity. It is antidiuretic, meaning it works against the production of urine. And in a healthy adult, its nightly rise is one of the most important physiological events that nobody ever thinks about. As the body prepares for sleep, ADH levels increase. The kidneys receive the signal and respond by reabsorbing water more aggressively from the filtrate passing through the collecting ducts, producing smaller volumes of highly concentrated urine and dramatically reducing the load delivered to the bladder. A healthy adult with robust ADH function can sleep 7 or 8 hours and wake once, or not at all, regardless of what they drank at dinner. The hormone essentially puts urine production on a controlled pause for the night, coordinating with the body's circadian rhythm to protect the sleep window with hormonal precision. What the National Institutes of Health has documented across multiple aging studies is a consistent and clinically significant pattern. As adults move through their 50s and 60s, the circadian rhythm governing ADH secretion begins to flatten. The evening surge that once rose reliably as darkness fell becomes less pronounced, less predictable, and in some individuals, effectively absent. The kidneys, receiving a weaker or mistimed hormonal signal, don't shift into conservation mode the way they once did. Urine production continues through the night at rates closer to daytime levels. The bladder fills on a schedule it was never designed to maintain during sleep, and the person wakes, not because anything has broken dramatically, but because a regulatory system that once operated with quiet precision has gradually lost its edge. This erosion matters beyond the inconvenience it produces. The kidney's ability to concentrate urine at night, to produce small volumes of dense, concentrated urine rather than large volumes of dilute urine, is a functional marker of renal reserve, the excess capacity the kidneys maintain above their minimum requirements. Young, healthy kidneys can concentrate urine to remarkable degrees. Kidneys that have navigated decades of hypertension, chronic low-grade inflammation, or metabolic dysregulation lose that concentrating ability incrementally in ways that don't always register on standard blood tests, until the loss is substantial. A careful look at nocturnal urine volume and concentration can reveal the early edges of that decline long before creatinine or eGFR numbers move outside their reference ranges. What makes this particularly worth understanding is the relationship between ADH function and sleep quality, and the direction in which that relationship runs. Poor sleep disrupts the hormonal environment that supports ADH secretion. Fragmented sleep, shallow sleep. Sleep shortened by any cause reduces the depth and duration of the circadian signals that trigger the evening ADH surge, which means that nocturia degrades sleep, and degraded sleep worsens the hormonal regulation that was supposed to be preventing nocturia. The loop is quiet and self-reinforcing, and it can run for years before anyone identifies it as a loop rather than a fixed condition. People assume they have simply arrived at a new baseline. What they have actually arrived at is a feedback pattern with identifiable entry points. Entry points that, with the right clinical attention, can be interrupted. There is also a secondary mechanism worth holding onto because it connects directly to what comes next. The ADH system does not operate in isolation. It is sensitive to signals from other physiological processes occurring during sleep, including signals generated by the respiratory system when breathing becomes obstructed. And the way those respiratory signals interact with ADH, with the heart, and with the kidneys to produce nighttime urine is one of the most surprising and underappreciated pathways in this entire story. There is a condition affecting an estimated 30 to 40% of adults over 50 that most of its carriers have never been formally told they have. They know certain things, that they snore, that they wake up tired regardless of how long they slept, that their energy in the afternoon feels unreliable, that a partner has mentioned more than once that their breathing does something strange in the night. These details have been noted, perhaps mentioned to a doctor, perhaps attributed to weight or age or stress, and largely set aside. What most of them don't know is that this condition, obstructive sleep apnea, may be one of the primary reasons they are waking up to urinate at night, not a contributing factor. For some people, the dominant mechanism. The pathway is mechanical, and it is worth following carefully because it is genuinely surprising. When the soft tissue of the upper airway relaxes during sleep and collapses inward, blocking the passage of air, the body continues trying to breathe. The chest muscles contract. The diaphragm drives downward with increasing effort. But because the airway is obstructed, no air moves, and that effort against a closed system generates a powerful negative pressure inside the thoracic cavity, the space in the chest that houses the heart and lungs. That negative pressure is not benign. It physically distorts the walls of the heart, pulling outward on the atrial chambers in a way they are not designed to experience during sleep. The right atrium, in particular, stretches under that repeated mechanical strain. The heart interprets that stretch as a signal that the body is volume overloaded, that it contains more fluid than it should. It responds by releasing atrial natriuretic peptide, ANP, a hormone whose specific function is to instruct the kidneys to excrete sodium and water and reduce circulating volume. The kidneys comply. Urine production increases. The bladder fills. And the person wakes, not because their bladder is overactive, not because they are drinking too much, but because their heart sent a false emergency signal triggered by obstructed breathing, and their kidneys executed the order without question. Research published in the journal Sleep and supported by subsequent work referenced in American Academy of Sleep Medicine guidelines has documented this pathway with considerable precision. Patients with moderate to severe obstructive sleep apnea show significantly elevated ANP levels during sleep, and those elevated levels correlate directly with increased nocturnal urine volume. The more severe the apnea, measured by the frequency and duration of obstructive events per hour, the greater the ANP release and the greater the nocturnal urine production. The bladder is not the variable. The airway is. What makes this finding clinically transformative is what happens when the apnea is treated. Patients who achieve consistent CPAP continuous positive airway pressure, the device that maintains an open airway throughout the night by delivering a steady stream of pressurized air, show normalization of ANP levels during sleep. Nocturnal urine production decreases. Nocturia frequency improves, often substantially, within weeks of initiating therapy, without any change to fluid intake, bladder training, prostate treatment, or urological medication. The improvement is not incidental. It is mechanistically direct. Remove the obstructed breathing, eliminate the false volume overload signal, stop the unnecessary urine production. People who have spent years adjusting their evening routines, last drink at 6, bathroom at 9:30, again before bed, again at 1, again at 3. Some of them were one sleep study away from a meaningful resolution. The bladder was never the problem. The airway was, and the heart was the interpreter standing between them, doing its job flawlessly in response to a signal it was never supposed to receive. This is the kind of connection that reorganizes how a person thinks about their own body. It asks for a wider frame, not just the organ producing the symptom, but the full system generating the conditions that make the symptom inevitable. And that wider frame, applied to one more common condition in adults over 50, reveals a mechanism that has been operating silently in millions of people for years, signaling its presence every single night in the only language available to it. Type 2 diabetes has a well-known public face: the diagnosis, the medication, the dietary adjustments, the regular monitoring. What it also has, less visibly, is a long and largely silent prologue. The average person living with type 2 diabetes spent somewhere between 7 and 12 years in a metabolic state that was already dysregulated before anyone gave it a formal name. Blood sugar elevated but not yet diagnostic. Insulin resistance building. The pancreas compensating with increasing effort for a system becoming progressively less responsive to its signals. The American Diabetes Association estimates that more than 96 million American adults are currently in this pre-diabetic state. The majority have no idea. What many of them do have is nocturia. The connection is direct and operates through a mechanism the body cannot override once it is in motion. When blood glucose rises above approximately 180 milligrams per deciliter, the threshold at which the kidneys can no longer fully reabsorb glucose from the filtrate, passing through the renal tubules, glucose spills into the urine. And because glucose is osmotically active, it pulls water along with it as it goes. The urine volume increases substantially. The kidneys are not malfunctioning. They are doing precisely what they are designed to do: diluting the glucose they cannot recapture, excreting it safely, protecting the body from the consequences of sustained hyperglycemia. The consequence of that protection, however, is a bladder that fills faster and more fully than it should at any hour, including the hours designated for sleep. Nighttime is particularly problematic in this context for a reason that doesn't get enough attention. The liver, operating on its own hormonal cues during sleep, continues releasing glucose into the bloodstream through hepatic glucose output, a process that, in metabolically healthy individuals, is well regulated and modest. In people with insulin resistance, that regulation loosens. The liver releases more glucose than the body needs during the overnight fast, blood sugar climbs during sleep, and the kidneys respond with increased urine production during the precise hours when the body has the least capacity to compensate. The person wakes at 2 in the morning, not knowing that their fasting glucose has been doing this, quietly, for years. This is one of the clearest arguments for including a hemoglobin A1C in the evaluation of any adult over 50 presenting with nocturia. The A1C measures the average blood glucose level over the preceding 3 months, capturing patterns that a single fasting glucose measurement on the morning of a blood draw will miss entirely. A person can present with a normal fasting glucose and still carry an A1CE that reveals significant nocturnal glucose excursions driving excess urine production every night. The snapshot looks clean. The 3-month average tells a different story. The timeline matters here in a way that is difficult to overstate. 7 to 12 years of undiagnosed metabolic dysregulation is not an abstraction. It is 7 to 12 years during which the small blood vessels supplying the kidneys are being exposed to glucose levels that gradually damage their walls. It is 7 to 12 years during which the autonomic nerves governing bladder sensation and detrusor muscle function are accumulating the kind of low-grade damage that eventually adds a genuine neurological component to what began as a purely metabolic problem. By the time both mechanisms are operating simultaneously, renal concentrating impairment from early nephropathy and bladder dysfunction from early neuropathy, the nocturia can become severe, and tracing it back to its metabolic origin requires a clinician willing to look well beyond the most recent urinalysis. The body was never being arbitrary. It was reporting a metabolic process through the only channel available at 2 in the morning. A bladder that should have been resting but wasn't, filling with urine that shouldn't have been produced but was, driven by blood sugar that nobody had yet connected to a bathroom trip in the dark. The signal was there the entire time. It just needed someone to read it correctly. And for a substantial number of people, the signal has been partially generated by something sitting in plain sight on the nightstand or in the medicine cabinet, something prescribed with good reason, taken faithfully, but doing something to nighttime urine production that nobody ever mentioned when the prescription was written. The average American over 60 takes 4 or more prescription medications. Most of those people have never had a conversation, not a real one, not a specific one, about what those medications do to urine production at night. Not because the information doesn't exist, it exists in the prescribing literature, in the pharmacology textbooks, in the package inserts that nobody reads past the first paragraph. It just rarely makes it into the clinical encounter in a form that connects a pill taken at 7 in the morning to a bathroom trip at 2 in the morning. That connection, once made, can change the entire picture. Start with the most direct example. Diuretics, thiazides, loop diuretics, aldosterone antagonists are among the most commonly prescribed medications in adults over 60, used widely for hypertension and heart failure. Their mechanism is explicit and intentional. They increase urine output by reducing the kidney's reabsorption of sodium and water. That is the therapeutic goal, and it works. Blood pressure comes down, fluid burden on the heart is reduced, clinical outcomes improve. But the timing of that increased urine production depends entirely on when the medication is taken and how long its effect lasts. And for decades, the default instruction has been simple and unexamined. Take it in the morning. A diuretic taken at 7 in the morning reaches peak effect somewhere between 2 and 6 hours later. For many patients, the drug has largely completed its work by early evening. But for others, particularly those on longer-acting formulations, or those whose hepatic and renal clearance has slowed with age, as it reliably does, the diuretic effect extends well into the night. The kidney is still receiving the signal to excrete sodium and water at 11 p.m., at midnight, at 2 in the morning. The bladder fills, the person wakes, and the clinical note reads, nocturia, likely age-related, advised to reduce evening fluid intake. The adjustment available here is almost embarrassingly simple. Research published in geriatric pharmacology literature has shown that shifting diuretic dosing to early afternoon, not morning, not evening, but a window that allows peak effect to occur during waking hours, reduces nocturnal urine production meaningfully in a significant proportion of patients without changing the drug, the dose, or the therapeutic outcome. Same medication, same clinical benefit, different timing. And the nocturia that had been present for 2 years improves within days. This finding has been available in the literature for years. The number of patients whose diuretic timing has ever been revisited in the context of their nocturia remains, by any reasonable estimate, far smaller than it should be. Calcium channel blockers introduce a different but related mechanism. Widely prescribed for hypertension and certain arrhythmias, these medications cause peripheral vasodilation. They relax the walls of blood vessels throughout the body, which is precisely how they lower blood pressure. A documented side effect of that vasodilation, particularly in the lower extremities, is peripheral edema. The same fluid accumulation in the legs and ankles that drives the cardiovascular nocturia mechanism described earlier. The medication isn't producing nocturia directly. It is creating the physiological conditions for the overnight fluid redistribution that does. A patient on a calcium channel blocker who also has mild venous insufficiency may be experiencing nocturia through two converging pathways simultaneously, neither of which has anything to do with their bladder. Alcohol occupies a distinct but relevant position in this conversation. It is not a prescription, but it functions pharmacologically in ways that bear directly on nighttime urine production. Alcohol suppresses ADH secretion in a dose-dependent and time-dependent manner, reducing the kidney's water conservation response for several hours following ingestion. The suppression peaks roughly 2 to 3 hours after consumption. For someone who drinks a glass of wine with dinner at 7, that peak ADH suppression arrives during the first hours of sleep, producing a burst of dilute, high-volume urine precisely when the body's hormonal system should be doing the opposite. The evening drink and the 2 a.m. waking feel unconnected. The pharmacology connects them directly. None of this is an argument against medication or wine or any of the clinical decisions that led to these prescriptions. It is an argument for looking at the full pharmacological environment a person over 50 is living inside of, drug by drug, timing by timing, mechanism by mechanism, and asking, specifically and without assumption, whether any of it is contributing to what wakes them at night. Because the answer, more often than most people expect, is yes. And the intervention required is not a new prescription. It is a conversation, a timing adjustment, and the willingness to treat a symptom that has been present for years as something worth actually solving. What that symptom costs in falls, in cognitive decline, in cardiovascular health, in years of life, is a number most people have never been given. And it is significantly larger than the inconvenience framing suggests. When people describe nocturia to their doctors, the word they most often use is annoying. It disrupts sleep, it requires adjustment, it has reshaped the logistics of the night in ways that feel permanent and mildly embarrassing. Annoying is an understandable frame. It is also, the data shows, a frame that dramatically underestimates what is actually happening to the body across months and years of interrupted sleep. Because nocturia is not simply less comfortable than uninterrupted sleep, it is physiologically distinct from it in ways that accumulate silently and eventually show up in some of the most consequential health statistics available for adults over 60. Start with the most immediate risk, because it is the most visceral. The National Institute on Aging identifies nighttime bathroom trips as one of the leading situational contributors to falls in adults over 65. Not as a footnote, but as a primary mechanism in a public health problem that costs the United States more than $50 billion annually in medical expenditures. The conditions are specific and predictable. The person wakes from deeper sleep in a state of partial disorientation, blood pressure not yet adjusted to upright posture, postural muscles slow to activate, the path navigated in low light or darkness, sometimes without glasses, sometimes on flooring that offers less traction than it appears to. Falls in this context are not random. They are the convergence of known physiological vulnerabilities at a known time of night, producing outcomes, hip fractures, traumatic brain injuries, hospitalizations, loss of independent living, whose severity bears no proportion to the apparent simplicity of a trip to the bathroom. The deeper cost, though, is what fragmented sleep does to the brain over time. Sleep architecture is not a passive state. It is an active biological process with a specific internal structure. Cycles of light sleep, deep non-REM sleep, and REM sleep that must complete in sequence to deliver their restorative functions. Deep non-REM sleep is when the body repairs cardiovascular tissue, regulates cortisol, consolidates procedural memory, and, critically, activates the glymphatic system, the brain's dedicated waste clearance pathway. The glymphatic system operates almost exclusively during deep sleep, using cerebrospinal fluid to flush metabolic byproducts from brain tissue, including amyloid beta, the protein whose accumulation is the defining pathological feature of Alzheimer's disease. A person who wakes twice per night is not getting half the restorative benefit of uninterrupted sleep. They may be getting significantly less, because deep sleep cycles that were building toward their most productive phases get truncated at interruption and must restart, incompletely, inefficiently, before the next awakening arrives. Research from Harvard Medical School and the National Institute on Aging has shown that chronic sleep fragmentation in adults over 60 is associated with accelerated cognitive decline, increased risk of mild cognitive impairment, and a measurably higher likelihood of dementia diagnosis within a 10-year follow-up period. The proposed mechanism runs directly through glymphatic efficiency. Consistent interruption of deep sleep reduces amyloid clearance. Amyloid accumulates in the interstitial spaces of brain tissue. The risk profile for neurodegenerative disease shifts, and the process that initiated the sleep fragmentation, the nocturia, the upstream cardiovascular or hormonal or respiratory dysfunction driving it, continues unaddressed while the cognitive consequences develop on their own timeline. If you've found what this channel does useful, the depth, the honesty, the refusal to simplify what deserves to be understood fully, subscribe and share this video with someone in your life who needs to hear it. What comes next is the part of this conversation that most people never reach. Not what nocturia costs, but what actually resolves it. The cardiovascular data closes the picture. A study published in JAMA Network Open examining nocturia frequency and cardiovascular outcomes found that adults waking 2 or more times per night had significantly elevated rates of hypertension, left ventricular hypertrophy, and cardiovascular mortality compared to those who slept through. The association persisted after adjusting for age, obesity, and sleep apnea, meaning the sleep fragmentation itself, independent of whatever was causing the nocturia, contributed meaningfully to cardiovascular risk. The heart's nighttime recovery window was being interrupted repeatedly, and the myocardium was among the tissues paying the price across years of accumulated disruption. Taken together, what this evidence describes is not an inconvenience with a footnote about falls. It is a clinical exposure, something the body is subjected to night after night, year after year, with documented consequences for cognitive trajectory, cardiovascular integrity, metabolic function, and longevity. Treating it is not about sleeping more comfortably. It is about protecting the systems that determine how well and how long a person lives. And the question that follows naturally from that framing is the one this entire video has been building toward. Given everything that has been described, the mechanisms, the systems, the upstream causes, what actually works? The interventions that genuinely reduce nocturia in older adults share a defining characteristic that is worth stating before anything else. They target mechanisms, not symptoms. They don't ask the bladder to hold more, don't reduce its sensitivity to the signals it receives, don't train the person to void on a schedule designed to preempt the problem. They ask the body to produce less urine at night, or they correct the upstream condition generating the excess in the first place. That distinction between managing a symptom and resolving its source is the organizing principle behind everything that follows. And it is a distinction that changes not just which intervention a person tries, but how they think about what they are trying to solve. The most consistently effective non-pharmacological intervention for nocturnal polyuria, driven by cardiovascular fluid redistribution, is also the least dramatic. Afternoon leg elevation. A man who had been waking twice a night for 3 years, faithfully avoiding fluids after 6, voiding before bed, doing everything his urologist suggested, tried elevating his legs for 60 minutes before dinner on the recommendation of a cardiologist who had finally connected his mild ankle swelling to his nocturia. Within 2 weeks, he was waking once, sometimes not at all. Nothing else had changed. The mechanism is straightforward. Fluid, that accumulated in the lower extremities across the day re-enters the circulation before sleep rather than during it. The kidneys process the extra volume while the person is still awake and upright, and the nocturnal urine production it would have triggered simply doesn't occur. Research referenced in European urology guidelines has documented meaningful reductions in nocturnal urine volume with this intervention alone in patients with lower extremity fluid accumulation. Compression stockings worn during the day limit the degree of fluid accumulation in the interstitial tissue before it has a chance to build, reducing the volume available for overnight redistribution at its source. Dietary sodium reduction carries a parallel benefit that rarely gets named in this context. Lower sodium intake reduces the osmotic load the kidneys must manage overnight, which reduces nocturnal urine volume in a manner documented in trials focused specifically on nocturia outcomes. The American Heart Association's guidance on sodium reduction for cardiovascular health and the clinical evidence on nocturia point toward the same dietary adjustment, the cardiovascular benefit and the sleep benefit arriving together from a single change. For patients whose nocturia is driven by obstructive sleep apnea, CPAP therapy normalizes atrial natriuretic peptide levels during sleep, eliminates the false volume overload signal to the kidneys, and reduces nocturia frequency in many patients within the first 2 to 4 weeks of consistent use, without touching the bladder, the prostate, or anything the standard urological pathway would have addressed. The medication timing adjustment for diuretics is perhaps the most immediately accessible intervention of all, and among the most underutilized. Moving a diuretic from morning to early afternoon dosing requires no new prescription, no change in drug or dose, no additional cost. It requires one specific, informed conversation with a prescribing physician. A conversation worth preparing for by arriving with a voiding diary, documenting the timing and approximate volume of nighttime voids over 5 to 7 days, a current medication list with dosing times, and a direct question. Has nocturnal polyuria been considered as the primary mechanism here, and what evaluation would be appropriate to identify which upstream cause is driving it? That question, precise, clinical, grounded in everything this video has covered, redirects the encounter from symptom management to mechanism identification. And that redirection, more than any single intervention, is what separates years of quiet adjustment from a genuine resolution. There is a particular kind of relief that comes not from solving a problem but from finally understanding it correctly. From realizing that the body wasn't failing arbitrarily, it was communicating precisely, through the only channel available at 2 in the morning, about processes that deserved attention and were capable of being addressed. That reframing matters. It is the difference between a person who manages a symptom indefinitely and a person who asks the right question once and changes the entire trajectory. If this video gave you that question, or gave it to someone you love, share it with 5 people in your life who are navigating their health with the same seriousness you bring to yours. Subscribe if you haven't already, and leave a comment telling us what you want to go deep on next. The topics that keep coming up in your own health conversations, the questions that haven't been answered clearly yet. The best work this channel does begins exactly there.